Bonjour tout le monde. Buongiorno a tutti. Naimbag na bigat. Kakabsat kan gagayem. So welcome for today's session. Part 1 will be about anatomy and physiology for your exam 2. Part 2 will going to be about biochemistry. So let's begin so that we can make progress. So ventral wall defects. So these are defects due to what? Failure of rostral fold closure or caudal fold closure or lateral fold closure. Rostral fold closure meaning you have some defect in the sternum. Lateral fold, examples, omphalocele and gastroschisis, or you have a caudal fold closure. For example, you have your bladder exystrophy. So there are two high yield here. One, gastroschisis, and two, omphalocele. Let's talk about gastroschisis. What is this? You have a extrusion of the abdominal contents through the abdominal folds, typically right of umbilicus. It is not covered by peritoneum, and it is not associated with chromosomal abnormalities. Contrast that with omphalocele. Omphalocele is failure of lateral walls to migrate at the umbilical ring, so you have a persistent midline herniation of the abdominal contents. It is surrounded by your peritoneum. It is also associated with congenital anomalies. You have trisomies 13 and 18. Also, it can also be seen in trisomies 21. For trisomy 21, can you give me like signs and symptoms of someone who has that disorder? Anyone?
It's Down syndrome, so they would have.
Go ahead.
They would have the palmar crease, the broad nose bridge.
Okay, good. Smooth philtrum, low set ears. Right, exactly. In terms of the quad screen, what can I see in the quad screen that tells me it is Down syndrome? Anyone? What can tell me in the quad screen that it is Down syndrome? I can't hear you. Some of you I can't hear.
Alpha fetoprotein.
Is it gonna be like the
Okay, so for example, in AFP, is it increase or decrease in Down syndrome?
I think it's decreased.
It is decreased. Excellent. So most of the trisomies, AFP, they are decreased. The only time that you can have an increase in alpha fetoprotein is if you have spina bifida, myelomeningocele, all of those kinds, right? How about in terms of beta HCG? What happens in trisomy 21? Beta HCG and inhibin is increased, right? So increased beta HCG, increased inhibin for trisomy 21, decrease in alpha fetoprotein. That's trisomy 21. How about trisomy 18, trisomy 18? This is your Edwards syndrome. Can you give me signs and symptoms of someone who has trisomy 18?
They have a prominent occiput.
Excellent.
They have
the rocker bottom feet.
Rocker bottom feet, prominent occiput, excellent. The clenched fist, don't forget that one. Clenched fist. How about trisomy 13? Trisomy 13, the Patau syndrome. Signs and symptoms. So you have holoprosencephaly, right? Holoprosencephaly. You also have cleft lip and cleft palate. So they all begins with the letter P, holoprosencephaly, and cleft lip and cleft palate for trisomy 13. So let's summarize this ventral wall defects. Gastroschisis, extrusion of abdominal contents through the abdominal folds, not covered by peritoneum and not associated with chromosomal abnormalities. Omphalocele, failure of the lateral walls to migrate to the umbilical ring. It is surrounded by peritoneum. It is associated with congenital anomalies or trisomies and other structural abnormalities. Okay? Put a star here, that's high yield. Next one, let's talk about tracheoesophageal anomalies. So you have esophageal atresia, meaning the esophagus doesn't develop perfectly, with distal tracheoesophageal fistula. Fistula is just an abnormal communication between two organs. So it often presents as polyhydramnios in utero. Why do we have polyhydramnios in someone who has TEF?
They're not able to consume the amniotic fluid.
Exactly.
To the stomach.
Excellent. So the fetus cannot swallow the amniotic fluid. So what can you see in the neonate who has a TEF? So they drool, they choke, they vomit with the first feeding. Remember, TEFs, they allow air to enter the stomach. So you can actually see a gastric bubble when you do a chest x-ray. Of course, there is cyanosis for the baby. Why? You have laryngospasm. So to avoid aspiration, the airways have laryngospasm. So how are we going to test TEF? So if the test was going to be, you need to pass a NG tube, a nasogastric tube, to the stomach. And if it doesn't, if you feel resistance, then the baby has TEF. Do I need to know the different kinds of TEF, like pure esophageal atresia, pure TEF, H-type, and EA with distal TEF? I think for now, no. But when you go to term 4 and term 5, this 3 is important, okay? So let's summarize. Tracheoesophageal anomalies. What is this? This is esophageal atresia with distal tracheoesophageal fistula. It is often presents as what? Polyhydramnios in utero. Why? The fetus is unable to swallow amniotic fluid. What can we see in a newborn, in a neonate? Drooling, choking, and vomiting with first feeding. The neonate can have cyanosis. How? Due to laryngospasm. Why? To avoid reflux-related aspiration. How am I going to test this? Failure to pass nasogastric tube into the stomach. Let's talk about intestinal atresia. So this is bilious vomiting and abdominal distension within the first 1 to 2 days of life. So there are two kinds, duodenal atresia and jejunal and ileal atresia. So duodenal atresia, what's the embryological defect? Failure to recanalize. In the x-ray, you look at the figure on the left, you have a double bubble sign. You can see a stomach that's so big, right, on the left side, and then a proximal duodenum that's also dilated. So this is associated with your Down syndrome. Jejunal and ileal atresia, these are a disruption of your mesenteric vessels. So you have ischemic necrosis of the fetal intestine. The bowel becomes discontinuous, and the x-ray will going to show dilated loops of small bowels. So what is intestinal atresia? It presents with bilious vomiting and abdominal distension. Atresia meaning failure to form, the organ fails to form. Okay, so duodenal atresia, why do you have a dilated stomach and a proximal duodenum? Because of the GI tract failure to recanalize. What can you see in the x-ray? Double bubble sign. It's commonly associated with what? Trisomy 21, Down syndrome. Jejunal and ileal atresia, very low yield compared to duodenal atresia. This is due to disruption of your mesenteric vessel. So your superior mesenteric artery is not developed. So you have necrosis of your fetal intestine. You can see segmental resorption when you do an x-ray, right? You have dilated loops of small bowel with air fluid levels. Hypertrophic pyloric stenosis. Hypertrophic, the muscle is big, getting bigger. Pyloric stenosis, stenosis meaning the lumen is smaller, right? stenosis. So this is the most common cause of what? Gastric outlet obstruction in infants. What can we see in the baby? For hypertrophic pyloric stenosis, palpable olive-shaped mass in the epigastric region. So when you palpate, you can see an olive-shaped mass. You can also see visible peristaltic waves and high-yield non-bilous projectile vomiting at 2 to 6 weeks old. More common in what? Firstborn males. This is associated with exposure to your macrolides, your erythromycins. This results in metabolic alkalosis. Don't forget from term 1. Why? Because you are vomiting gastric acid, right? Metabolic alkalosis. You are vomiting gastric acid, and then the body tries to compensate, so you can develop volume contraction. What can we see in ultrasound? You can see the picture on the lower left, thickened and lengthened pylorus, right? So what's the treatment? So just surgical incision of your pyloric muscles. Let's summarize. Hypertrophic pyloric stenosis. What is this? Most common cause of gastric outlet obstruction in infants. What can we see? Palpable olive-shaped mass, visible peristaltic waves, non-bilous projectile vomiting. More common in firstborn males, associated with exposure to macrolides, your erythromycins. Results in what? Metabolic alkalosis due to vomiting of gastric acid and subsequent volume contraction. What can we see in the ultrasound? Thickened and lengthened pylorus. So what's the treatment then? If the pylorus is thickened, what can we do? Myotomy. You do pyloromyotomy. You just incise the pyloric muscles. Now, pancreas and spleen embryology. So pancreas, where is it derived? Is it derived from foregut, midgut, hindgut for your pancreas?
Foregut.
So foregut, right? So there are two parts, your ventral pancreatic bud and your dorsal pancreatic bud, high yield. In the ventral pancreatic bud, it becomes what in an adult?
The head.
So the head of the pancreas, so we call this one the uncinate process, and the duct of Wirsum. This is your main pancreatic duct. So that's high yield. The dorsal pancreatic bud, the rest. It becomes the body, the tail, the isthmus, and your accessory pancreatic duct. So there are two kinds of diseases associated with abnormal development of your pancreas. The most high yield here is the annular pancreas, although I've seen questions, NBME questions about pancreas divisum. So annular pancreas is abnormal rotation of the ventral pancreatic bud. It forms a ring of pancreatic tissue which encircles the second part of the duodenum. It causes duodenal narrowing, meaning the ventral pancreatic bud fails to fuse with your dorsal pancreatic bud. That's why it forms a ring of pancreatic tissue around the second part of your duodenum, which causes duodenal narrowing. Now contrast this one with your pancreas divisum. This is low yield, which is the dorsal and ventral part of the pancreas fail to fuse at 8 weeks. This is the most common though, right? However, this is asymptomatic, okay? You cannot have vomiting here, right? But this may cause chronic abdominal pain and or pancreatitis, okay? So annular pancreas, what is it? Abnormal rotation of your ventral pancreatic bud. It fails to fuse with the dorsal pancreatic bud, which forms a ring of pancreatic tissue around where? The second part of your duodenum, which causes what? Duodenal narrowing. Signs and symptoms you can have? Vomiting. Pancreas divisum, the most common. However, this is asymptomatic, but it can cause chronic abdominal pain and pancreatitis. The ventral and dorsal parts fail to fuse at 8 weeks. Now, the spleen is very, very peculiar in this aspect. Why? Because it arises in the mesentery of the stomach. So what is the embryological origin of the spleen? Is it ectoderm, mesoderm, or endoderm? What is the answer? For the spleen. Is it ectoderm, mesoderm, or endoderm? The embryological origin of the spleen.
Mesoderm.
Mesoderm, excellent. However, it has a foregut supply, the celiac trunk. So this is very, very peculiar. So put a star there. This is high yield. Spleen, embryological origin, mesoderm, right? It arises in the mesentery of the stomach. However, what's the foregut? What is the foregut supply? It's celiac trunk via your splenic artery. Okay. Next one, do I need to memorize the retroperitoneal structures? Yes, this is very high yield. So put a star here. What do we mean by retroperitoneal structures? It means those structures that are posterior to the peritoneal cavity. Don't forget, any injury with these structures, it can cause blood accumulation in your retroperitoneal space. Let's look at the lower right image. So you have suprarenal glands, aorta, IVC, duodenum, pancreas, ureters, colon, kidneys, esophagus, and the rectum. Please memorize these structures. Okay, this is high yield. Next, the ligaments. There's a lot of ligaments, but I'm only going to focus on the high yield stuff, right? Okay, so the falciform ligament, it connects the liver to the anterior abdominal wall. This is what's high yield here is it contains ligamentum teres hepatis, which is a derivative of your fetal umbilical vein, which is derived from your ventral mesentery. Okay, another high yield point here is the hepatoduodenal ligament, which connects your liver to the duodenum. Why? Portal triad is in there. So you have a proper hepatic artery, portal vein, common bile duct. What's the derivative of the structures? They're derived from your ventral mesentery. So if I'm doing abdominal surgery, I can do a Pringle maneuver. The ligament is compressed manually or with the clamp to control bleeding from the hepatic inflow source. Question, I'm doing a surgery and then there's bleeding. I perform the Pringle maneuver and there is still bleeding. The bleeding won't stop. So what vessel do you think is affected? Was accidentally cut?
The inferior vena cava.
Excellent. It's the inferior vena cava. Good job. So it borders the ligament, it borders the omental foramen, which connects the greater and lesser sacs. This is the part of your lesser omentum. The rest, I think you can just read short gastric, splenic artery and vein, tail of pancreas. So the two high yield ligament here, I think, is falciform ligament. Why? Because it contains your ligamentum teres hepatis. What is this? Ligamentum teres hepatis. This is the derivative of your fetal umbilical vein. Let's go back to term 1. What's the adult derivative of your ductus venosus? Remember the ductus venosus? This is your what? From term 1? What is this?
Ligamentum venosum.
Excellent. So what's in the fetal life? What does it do?
I think it shoves blood away from the liver.
Excellent. Because the liver is just developing, you don't need it there, right? How about foramen ovale? It becomes what in adult?
Blood.
So it becomes fossa ovalis, right? Foramen ovale, fossa ovalis. How about the ductus arteriosus? It becomes what?
That's the bacteria. But could you recap on the foramen ovale again? Because I remember the word, I forgot exactly what it did.
So fossa ovalis in adult, okay? So remember the foramen ovale? Why do we have foramen ovale? What's the embryological defect there?
A patent a patent a foramen. It shunts blood from the
Right atrium to the left
atrium to the
atrium, right?
left. Yeah.
Remember the formation of your foramen ovale. Either your secundum, what is that? The foramen secundum fails to close, or there's a defect in your, I forgot it already. But there's a shunting of the blood from your right atrium to the left atrium, so that it is, I think it's a cyanotic heart defect because it's a right to left shunt. How about ductus arteriosus? Ductus arteriosus, it connects your pulmonary artery to your aorta, right? What is the adult derivative of your ductus arteriosus?
Ligamentum arteriosum.
Excellent, very good. So this is your ligamentum arteriosum, and next term, when you go to the lab, look at this structure. This is very important. Your left recurrent laryngeal nerve, it hooks underneath your ligamentum arteriosum. So if you have any enlargement, for example, of your heart, any enlargement of your left atrium, it can cause constriction of your mediastinal structures, which can cause hoarseness because of that left recurrent laryngeal nerve, which hooks underneath your ligamentum arteriosum. Those are high yield. How do we keep the PDA open? What's the drug that you're going to give me to keep the PDA open? Prostaglandin, E1 and E2. To close the PDA?
Cox.
Any NSAIDs. Excellent. Any NSAIDs. Endomethacin, right? What is the murmur of a PDA?
Machine-like.
Continuous machine-like murmur. Where does the blood go in the fetal circulation? From where to where? From pulmonary artery to aorta. But at birth, due to a reverse in pressures, the blood goes from, if there's a patent PDA, the blood goes from aorta to the pulmonary artery. More to come when you're in term 4. All right, next. Anatomy tract. This is high yield. Put a star here. The layers of the gut wall. So mucosa, what can we find there? You can find the epithelium. You can find the lamina propria, muscularis mucosa. Beneath that is your submucosa. What's in there? High yield submucosal nerve plexus. These are your Meissners. What's the function? It secretes fluid. Underneath that, you have the muscularis externa. This includes the myenteric plexus. This is your Auerbach plexus. What's the function? Motility. And of course, serosa when it's intraperitoneal, and adventitia when it is retroperitoneal. Don't forget your sudpuckers, right? The outermost layer is the adventitia. Let's summarize the layers of the gut wall. Mucosa, this is closest to the lumen, okay? What can we find there? Epithelium, you can have lamina propria, you can have the muscularis mucosa. In the submucosa, you can find the submucosal nerve plexus, your Meissners, high yield. It secretes what? A submucosa, it secretes fluid. Your muscularis externa, you can find the myenteric nerve plexus, your Auerbach plexus. It is for what? Motility. And if we have retroperitoneal organs, the outermost layer is the adventitia. If you have intraperitoneal organs, the outermost layer is serosa. Don't forget that ulcers can extend into the submucosa, the inner and outer muscular layers. Erosions are in the mucosa only. That's the difference. And also don't forget that the frequency of your electric rhythms, which originate from high-yield interstitial cells of Cajal, these are the ones that regulates the frequency of the slow waves of your GI tract. In the stomach, we have 3 waves per minute. In the duodenum, 12 waves per minute. In the ileum, you have 8 to 9 waves per minute. Another high yield, put a star here. Digestive tract histology. Let's go to A. What do you think A is? Go to the image and look at A. What do you think A is? We're looking at what organ here?
Stomach.
Stomach. Why do you think it's a stomach?
The parietal cells on the bottom. The egg shaped, or the whatever that kind of shape is. I forget.
Good job. So you can see what you have. You can see the gastric glands. You can see simple columnar epithelium. Don't forget that for your stomach. How about B? Let's go to B. Look at that image. Where do you think we are in the digestive tract? Look at B.
Is it the jejunum? Are we looking at the lacteals?
B. We're looking at the duodenum. Okay, so this is duodenum. As you can see, you can have villi and you have microvilli. What's the function of the villi and the microvilli? To increase your absorptive surface. You can also see an important gland, high yield, in the duodenum. The Brunner glands, what's the function? It secretes bicarb, right? And you can see crypts of Lieberkühn, which contain stem cells. And you can also see Paneth cells there that secretes defensives, lysozymes, and TNF. Okay, let's look at C. Where are we now? Someone said it a while ago. So we're in the jejunum. Excellent. So you can have villi, you can have crypts of Lieberkühn, and you can have plicae circularis. Next, D. Look at D. There's a very distinctive feature there that's highlighted by the arrow.
The Pyrex Patches.
Excellent. So when you see Pyrex Patches, think of the ileum. There's a vitamin that's very important, absorbed in the ileum, the terminal ileum. What is that vitamin?
B12.
Vitamin B12. How about in the jejunum?
The other vitamins? Oh.
Folate, or B9. How about in the duodenum? Iron. Iron. Okay, don't forget that. That's high yield. So look at D. When you see Pyrex Patches, think about the ileum. What else is in there? So you can have Pyrex, you can have plicae circularis, of course, but you can also have the crypts of Lieberkühn. Remember, the stem cells, right, that replace your enterocytes, they need to be there. And of course, Paneth cells, you know, which are immunological cells. Let's look at, you can also have goblet cells in the small intestine. How about E, the last one? We are now in the colon. So you can see there's no villi. This is not about absorption. We're done with absorbing nutrients. And you can also see crypts of Lieberkühn again there with abundant goblet cells. Okay, put a star here. Digestive tract histology, let's summarize. What's the important point, right? Esophagus is not, there's no image here, but don't forget esophagus, non-keratinized, stratified, squamous epithelium. The upper 1/3 is striated muscle. Middle and lower 2/3 are smooth muscle with some overlap at the transition. Why is this important that the upper 1/3 is striated and the middle and lower 2/3 smooth muscle? Because when you go to term 4, it depends upon what kinds of cancer can you have. Upper 1/3 is always squamous carcinoma of the esophagus. Lower 2/3, it's always adenocarcinoma. Okay. How about the stomach? Let's look at A. It's gastric glands. Look at B. This is your duodenum. What can we see? We can have villi and microvilli. Why? Because we need to absorb nutrients. This is for absorptive, to increase the absorptive surface. What else can we see there that's important? High yield Brunner glands. What does it do? It secretes bicarb. And what else in duodenum? Crypts of Lieberkühn. What's the function? It contains stem cells. Why? Because it replaces your enterocytes and the goblet cells. And you can also find Paneth cells there. These are your immunologic cells. They secrete what? Defensives, lysozymes, and tumor necrosis factor, or TNF. Let's look at C. C is the jejunum. We have villi, we have also the crypts of Lieberkühn, and we also have the plicae circularis. And D, don't forget, if you see that the Pyrex Patches, if you see lymphoid aggregates in your lamina propria and the submucosa, think about your ileum. This part of the GI tract has the largest number of your goblet cells. And last but not the least, E, look at that. When you see no villi at all, think about you're in the colon. You can also have the crypts of Lieberkühn there with abundant goblet cells. However, you don't see any villi. Now, let's look at the abdominal aorta and the branches, right? So these arteries, they supply the GI structures. They are single branches and they branch anteriorly to your aorta, okay? So there are different parts. You have your celiac trunk, which supplies what? Celiac trunk, it supplies what structures?
Foregut.
Foregut.
Superior mesenteric artery, it supplies what structure?
Midgut.
Midgut. Inferior mesenteric artery, it supplies what structures?
Hindgut.
Hindgut. Excellent. So if there is a question, there is an ischemia in my celiac trunk, can I still supply blood to my foregut structures? Yes or no?
If there's no, but isn't there one that's, I think the pancreas is going to get superior mesenteric and celiac? So wouldn't some of the pancreas get some blood?
Guys, be careful. There's an ischemia in the celiac trunk. Can I still supply my foregut structures? Yes. Why?
Anastomosis.
Excellent. So what is that anastomosis? Good job. So tell me the anastomosis between that connects your celiac from your SMA. There is an anastomosis. What is it?
Is it the inferior pancreaduodenum?
Excellent. Good job. Good job. So you have the superior, right, and inferior pancreatico-duodenal artery. Don't forget that one, guys. So even though you have ischemia in your celiac trunk, you can still have blood supply to your foregut structures because of that anastomosis. That's high yield. Now, let's talk about Nutcracker Syndrome. What is this Nutcracker Syndrome? High yield. Compression of your left renal vein between the SMA and the aorta. So it is a compression of what? A vein, specifically what? Your left renal vein. Why the left renal vein? Because it's much more longer. Remember, your right renal vein, it's much shorter. Okay, the left renal vein is much longer. It is compressed between the aorta and your SMA. Signs and symptoms: abdominal pain and gross hematuria. Contrast this one with your SMA syndrome. SMA syndrome is an obstruction to your superior mesenteric artery. When the SMA and the aorta, it compresses the third part of your duodenum. This typically occurs in conditions associated with low body weight, malnutrition, if someone has marasmus, or if they lose weight quickly. You can have superior mesenteric artery syndrome. Let's summarize. Put a star here. Celiac trunk supplies blood supply to your foregut. SMA supplies blood to your midgut. IMA supplies blood to your hindgut. Nutcracker syndrome, this is a compression of left renal vein between the aorta and the superior mesenteric artery. Signs and symptoms: flank pain and hematuria, blood in the urine. Why? You have a rupture of renal varicosities. SMA syndrome, you have an intermittent intestinal obstruction. Symptoms: this can be manifested after a meal, a postprandial pain. Why? The SMA and the aorta, they compress your third portion of the duodenum. Typically occurs where? Low body weight or malnutrition, and if you lose weight quickly. Okay? There you go. Put a star here. You need to know the embryologic gut region, the artery that's involved, parasympathetic innervation. Remember, foregut midgut is vagus, and the hindgut is pelvic, right? And don't forget the structures supplied from foregut, from the pharynx up to your proximal duodenum. The midgut is from the distal duodenum to the proximal 2/3 of your transverse colon. And the hindgut is the distal 1/3 of the transverse colon to your upper portion of anal canal. Put a star here. Know everything that's and on this slide. This is high yield. Again, don't forget the celiac trunk. You have different branches of the celiac trunk. You have the splenic artery here. The splenic artery. Question: if I have an ischemia on the splenic artery, what artery do you think will gonna be loss of blood supply? There will not be blood running into it. So if I obstruct my splenic artery, what artery will be affected? A, right gastroepiploic, B, left gastric, C, short gastric, D, gastroduodenal. Hello?
The short gastric, would that be?
Excellent. So you have the short gastric. Okay, that's high yield. Remember, the short gastric, it branches off your splenic artery. So any kind of blockage here, any kind of ischemia or thrombosis here, it will gonna affect your gastric. There are different anastomosis here. High yield, you have the left and right gastroepiploic, left and right gastroepiploic, and then you have the left gastric and your right gastric. So let's look at the celiac trunk. Two branches, right? It branches off splenic artery here, splenic artery. A branch of the splenic is short gastric. On the right, let's go here. You have the common hepatic, and it becomes proper hepatic, and then it branches off as left, right, and cystic. Okay, and your proper hepatic for the liver. There's another branch from the common hepatic. You have the gastroduodenal artery. The gastroduodenal artery has different branches. You can have the right gastroepiploic, which anastomoses with your left gastroepiploic coming off from the splenic artery. You can also have the pancreaticoduodenal arteries here. So what's the high yield point here? Celiac trunk. Okay, so this is the common branches, 3: common hepatic, splenic, and left gastric. What is the main point of the celiac trunk? This is the main blood supply of the foregut. There is a strong anastomosis here, where left and right gastroepiploics and left and right gastric. Another high yield. Hello?
I have a quick question.
Go ahead.
So back on the last slide, when we have some questions talking about the anastomosis between the pancreas, when you're talking about the gastroduodenal, if the gastroduodenal is just the part that's most superior, and then it splits into the like anterior, posterior, superior. So when they ask questions as for like if there's an ulcer that on the posterior side of the duodenum, what would be affected? Sometimes it says gastroduodenal, but is that too superior because it's too high and close off the branch?
If you have an ulcer in what part of the duodenum? Is it the proximal, the first part, second part, or third part? So the first part, right? Is it this in the vignette they're gonna specify, is it proximal or distal to the ampulla of Vater?
Oh, okay.
You didn't say anything? If you didn't say anything, you can say it's the gastroduodenal artery. That's the most what do you call this one? Inferior posterior part, I think. So if you rupture your first part of the duodenum, the first artery that can be affected is your gastroduodenal artery, right? It's don't forget the gastroduodenal artery. It's a very small blood vessel in your abdomen. It supplies blood to your pylorus, which is a distal part of your stomach, and of course, high yield, the proximal part of the duodenum. That's why they need to specify where. Is it proximal or distal to the ampulla of Vater? But I think if they just say, okay, there's something wrong with the first part of the duodenum, then assume there's an ulcer there, there's a rupture, assume that the gastroduodenal artery is the first artery that is affected. Okay?
Okay, thank you.
Good job. Next, this is another high yield point, guys. Put a star here. Portosystemic anastomosis. This is, so if you're back in Grenada, if you go to brewery, right? If you drink after an exam, you can develop what afterwards? No, I'm just joking. If you're a chronic drinker, you can develop portosystemic anastomosis, the alcoholics, right? So you need to know the site of anastomosis, the clinical sign, and what veins are involved. Okay, so first, what veins and arteries that are involved? So first is the esophagus. So the esophagus is here. You can see that one. So clinical sign is esophageal varices. So you have increase in pressure, intra-abdominal pressure, which causes your left gastric and your esophageal veins, they dilate here. So what are the veins that are involved? So we have the left gastric and your esophageal veins. Next, umbilicus. Let's look at umbilicus here. What's the clinical sign? Caput medusa, right? So what are involved? The paraumbilical and the small epigastric veins. Next is the rectum. So we have the anorectal varices. What's the anastomosis? Superior rectal and the middle and inferior rectal. So portal and systemic, I'm sorry, this is not about arteries, this is about veins. Portal meaning all of those on the left gastric, paraumbilical, and superior rectal, they drain to your hepatic portal vein. On the right one is systemic, your esophageal, your small epigastric, and abdominal, and middle and inferior rectal. They are systemic because they directly drain to your IVC. Why is this important? This is important when we talk about the dentate line. Anything that drains above the dentate line, it goes to your hepatic portal vein. Anything that drains below the dentate line, it goes directly to your inferior vena cava, therefore systemic. Okay, I apologize. So this is about veins. We're talking about veins. Where does it drain? Okay, so what's the high yield? High yield, know the site of anastomosis, know the clinical sign, and know the veins that are involved. Are they portal, meaning they drain to the hepatic portal vein, or are they systemic? They drain to the inferior vena cava. Okay, so you can see here, if you have a varices of your gut, butt, and caput, they're commonly seen with portal hypertension. Portal hypertension is commonly associated with chronic alcoholism, right? Or for example, if you have liver cirrhosis, or a chronic infection like hepatitis, viral hepatitis. So what's the treatment? Can we have some treatment? Yes, you can do a TIPS, your transjugular intrahepatic portosystemic shunt between where? I yield portal vein and the hepatic vein. Why? To relieve portal hypertension. How? By shunting the blood to the systemic circulation, bypassing the liver. Let's summarize. How to relieve portal hypertension, either due to chronic hepatitis, chronic alcoholism, or cirrhosis, via TIPS, transjugular intrahepatic portosystemic shunt. Between what two veins? Between the portal vein and hepatic vein. Why? To relieve the portal hypertension. How? By shunting the blood to the systemic circulation, bypassing the liver. Don't forget the TIPS can precipitate hepatic encephalopathy. So you can have increase in ammonia, right? Due to decreased clearance of ammonia from shunting. Remember, the liver is the place of your urea cycle. Okay? Good. Put a star here. This is a high yield slide. Again, when we talk about the dentate line, put a star here again. This is high yield. Remember, the dentate line is formed what? It's formed where your endoderm, the hindgut, meets the ectoderm. Let's talk about above the pectinate line. What's the nerve? The nerve is visceral innervation. Visceral, therefore, painful or not painful? It's visceral.
Not painful.
Not painful. Excellent. Look at the arterial blood supply. Superior rectal artery, branch of the inferior mesenteric artery. Veins, Remember, I talked about this one. The superior rectal vein drains to the inferior mesenteric vein, which drains to the splenic vein, which drains to the portal vein. So this is portal circulation. And the lymphatics, they drain to the internal iliac lymph nodes. Therefore, question, if I have a hemorrhoids above the dentate line, is it painless or painful?
Painless.
Painless. Excellent. Term 4, you're going to learn about adenocarcinoma, most common above the pectinate line. How about below the pectinate line? Below the pectinate line, what's the innervation? Somatic innervation. Therefore, it is painful if there's a thrombosis there. Arteries, inferior rectal artery, which is a branch of your internal pudendal artery. The inferior rectal vein, again, it drains to the internal pudendal, which drains to the internal iliac, which drains to the common iliac, which drains to inferior vena cava. And for the lymphatics, it drains to your superficial inguinal lymph nodes. Let's summarize. Dentate line. This is formed where your hindgut meets the ectoderm. Above the pectinate line, it's visceral innervation. Therefore, the internal hemorrhoids are not painful. The arteries, superior rectal artery, the veins, they drain to the portal circulation. And for the lymphatics, they drain to the internal iliac lymph nodes. Below the pectinate line, you have external hemorrhoids, somatic innervation. Therefore, it is painful. What branch for somatic innervation? The inferior rectal branch of your pudendal nerve. It is also supplied by your inferior rectal artery, which is a branch of your internal pudendal artery. The veins, they drain to your inferior vena cava. And for the lymphatics, they drain to the superficial inguinal lymph nodes. There's also a thing called anal fissure, which is a tear in the anal mucosa below the pectinate line. Therefore, it is painful because it's somatic innervation. The inferior rectal branch of pudendal nerve is involved. You can also blood on toilet paper. It is located posteriorly because this is poorly perfused, associated with what? Low fiber diets and constipation. But to start on this slide, this is high yield. Another high yield slide, the liver tissue and architecture. So this hexagonal unit of the liver, right, or lobule surrounding, you have a central vein here, right? It's a hexagonal structure. It has 6 sides, 1, 2, 3, 4, 5, 6. Centrally, you have the hepatic vein, and on the edges here, you can see the portal triad. Can you please tell me components of your portal triad? Hello?
A bile ductule.
So you have bile ducts. You have what else?
Hepatic artery and portal vein.
Excellent. So those are high yield. So your portal triad is your portal vein, hepatic artery, bile duct, and your lymphatics. So here you have on your apical surface, you have the hepatocytes. They face your bile canaliculi. So they face this bile canaliculi. And on your basolateral surface, they face the sinusoids. You also have specialized macrophages in there. We call them Kupffer cells. And they clear bacteria and damage to your senescent RBCs. High-yield hepatic stellate cells, your Ito cells, in space of this, they store vitamin A and they produce extracellular matrix. So if someone has cirrhosis, this hepatic cells, your Ito cells, they will gonna secrete TGF-beta, transforming growth factor beta, which is the cause of fibrosis in your hepatocytes. That's high yield. So when you think about hepatic stellate cells or Ito cells, it is located where? Space of this. It stores what? Vitamin A, and it secretes what? TGF-beta, the cause of hepatic fibrosis. Good. So there are different zones in your lobules, right? Much closer to the portal triad is your zone 1. The much closer to your hepatic vein is your zone 3. So zone 1, zone 2, zone 3. Zone 1, this is commonly affected by viral hepatitis. So If we have hepatitis B, of course, this is the most common zone that's affected. This also, if you ingest toxins, for example, if you use cocaine, zone 1 is the most commonly affected. Zone 2 is yellow fever. So if you have yellow fever, zone 2 is affected. Zone 3 is affected by ischemia. Why? It's farthest away from the portal vein. That's why this is affected first by ischemia. Don't forget, this is the highest concentration of your cytochrome P450. It's the most sensitive to metabolic toxins. So if you have TB, you're taking rifampin, or if you have headaches, or you're taking acetaminophen, or if you're chronic alcoholic, you keep on ingesting ethanol. Zone 3 is the most commonly affected. This is the site of alcoholic hepatitis. Okay, that's high yield. So let's summarize that one. Zone 1, viral hepatitis. Think about ingested toxins, cocaine, best oxygenated. Zone 2, yellow fever. Zone 3, farthest away from the portal triad, the closest to the hepatic vein. Therefore, this is affected by ischemia. It is the least oxygenated of all the zones, highest concentration of cytochrome P450, most sensitive to what? Metabolic toxins. If you think about drugs, rifampin, halothane, acetaminophen, ethanol, and CCl4. This is also the site of alcoholic hepatitis. So you can see the portal vein here, right? The portal vein, it drains to the hepatic vein. The bile goes on the other side. So it's the opposite. It's a counter transport, okay? Biliary structures. So you have the gallbladder here, you have the liver. Let's look at the ducts. So from the gallbladder, you have the cystic duct. The cystic duct, it combines with the common hepatic duct from the liver. You have the left and right hepatic duct from the liver. It joins to form the common hepatic duct. The common hepatic duct joins the cystic duct, which is connected to your gallbladder. They form together, they become the common bile duct. The common bile duct, it goes through your ampulla of Vater, and the bile is secreted. It is controlled by a sphincter called sphincter of Oddi. Okay, so any obstruction here, if I obstruct the cystic duct, what happens to the gallbladder? It can enlarge. If there's a blockage here, the common hepatic duct, your left and right hepatic duct, they're going to be enlarged. If it's a common bile duct, then that's much worse, right? So any form, any gallstones, right? It can block, especially if the gallstone is in the common bile duct. It can block both the common hepatic duct and your cystic duct, which can cause cholangitis. You're going to learn more of this in term 4. So there are a lot of tumors that arises from the head of the pancreas. So your ductal adenocarcinoma, which can cause obstruction. So another sign that you need to know, enlarged gallbladder with painless jaundice. This is your Courvoisier sign. You're going to learn more of this in term 4 and 5. So there's a tumor there which causes obstruction of the common bile duct. The gallbladder would be enlarged. However, you can have painless jaundice. Okay. And what if we check at cholangiography on the upper left side? You can see a filling defect. Look at the blue arrow here. You can see here the filling defect, and you have a narrowing of your cystic duct. Okay. So let's summarize here. Do I need to know the biliary structures? Yes. The basic anatomy, right? Don't forget that the gallstones that reach the confluence of your common bile and your pancreatic duct at the ampulla of Vater, they can block the common bile duct and pancreatic duct. So if the gallstone is here, ladies and gentlemen, if the gallstone is here, it can both block your common hepatic duct and your accessory pancreatic duct. It causes what? Cholangitis and pancreatitis. Okay, if there's a tumor arising on the head of the pancreas here, right? This is the head, the uncinate process. It can cause what? Obstruction of your common bile duct. So it can obstruct your common bile duct here. Can obstruct your common bile duct. What's the sign? Courvoisier's sign. What is this? You have enlarged gallbladder with painless jaundice. What can we see in cholangiography? You can see a filling defect in your gallbladder, and you have a cystic duct. This is high yield. We're talking about physiology, right? Do I need to know everything? You need to know the substance, what kind of cell secretes it, what's the action, and how do we regulate it. I think that's the most important thing for now. For the note part, more of this you're gonna learn in term 4 and term 5. So let's begin. Gastrin, the source is the G cells. What's the function? Increased gastric acid secretion, increased growth of gastric mucosa, and increased gastric motility. Aside from gastrin, how am I going to regulate acid secretion in the stomach? Aside from gastrin, give me another pathway. There are 3 pathways. So gastrin is one. What's the other one?
Are you talking about the parietal cells?
So the secretion of acid in the stomach, first you need to have gastrin, right? Give me another pathway.
That's
Parietal
gonna cause.
Okay,
Secrete.
parietal. So the parietal cells, they are the ones that are going to secrete, right? The H plus via gastrin. So what's the other pathway? Did you hear about acetylcholine? So remember, acetylcholine from your vagal, post-vagal afferent, right, from the vagus nerve. It can also increase the secretion of your hydrochloric acid. It can also induce your parietal cells to secrete HCl. Another one is, aside from acetylcholine, histamine. Histamine via what? Enterochromaffin-like cells, right? Which induces your parietal cells to also increase your secretion of H+. Okay, are we all clear on that one? So this is very, very important. Why? Because when you go to term 4, you're gonna learn about the drugs that decreases H+ secretion. Okay, and they act on these 3 important pathways. Gastrin, either you inhibit gastrin, either you inhibit acetylcholine secretion from your post-vagal efferent, or you decrease histamine. So you're gonna learn about histamine blockers, ranitidine, your Zantac, and then you can have sodium potassium ATPase blockers. So you got omeprazole and lansoprazole, all of those stuff. More of this in terms 4 and 5. But for now, no gastrin, no the source, G cells, no the action. How are we going to regulate this one? If the pH of the stomach is less than 1.5, the gastrin is decreased because we are now in acidic environment. So this is increase in chronic PPI, proton pump inhibitor, and chronic atrophic gastritis, and Zollinger-Ellison syndrome, which is a gastrinoma. You have too much gastrin in the stomach. Next, somatostatin. Somatostatin, the source is the D cells. It decreases everything. Look at the action. It decreases gastric acid secretion, pancreatic small intestine secretion, gallbladder contraction, insulin and glucagon release. So in a way, you say it decreases everything. Think somatostatin. Term 4, you're going to learn about octreotide, which is an analog of somatostatin. This is used to treat acromegaly, carcinoid syndrome, and variceal bleeding. Another one, cholecystokinin, source, the I cells in the duodenum and jejunum. What's the action? Increased pancreatic secretion and increased gallbladder contraction. This is, you increase CCK production if you have too much fat or amino acids in your meal. Okay, secretin, secreted by the S cells in the duodenum. It increases the pancreatic bicarb secretion. So if it's acidic, remember the acidic the stomach is acidic. If it goes to the duodenum, it damages the cells in the duodenum. Therefore, the duodenum secretes secretin to neutralize that acidic, that HCl that comes from your stomach. So remember, it neutralizes gastric acid in the duodenum. Why? To allow your pancreatic enzymes to function. So that's your secretin. Glucose-dependent insulinotropic peptide. The only question for this one that I can remember is if you give oral glucose load, right, rather than IV glucose, it increases the insulin level more compared to IV equivalent. Why? Because of this substance, glucose-dependent insulinotropic peptide. Okay, so in the vignette, if they say you were given oral insulin and they measure your, they give you an oral glucose instead of an IV glucose load, and then they measure your insulin, the oral glucose load increases the insulin level. And why? Because of this substance, glucose-dependent insulinotropic peptide, secreted by the K cells, the duodenum and the jejunum. Motilin, when you think about motilin, think about migrating, motor, complexes. If you're dieting, motilin is increased, right? This is increased in fasting state, okay? And VIP is important in secretion of water and electrolytes. So if you have VIPoma is a pancreatic cell tumor, right? That secretes VIP. You can have watery diarrhea, hypokalemia, and achlorrhea. This is the WDHA syndrome. You're gonna learn more in term 4 for this, okay? So put a star here. What do I need to know? You need to know the regulatory substance. You need to know the source. What part of the GI tract, what kind of cells is producing this regulatory substance? What parts of the GI tract is it found? What's the action? Okay. Regulation. And for the notes, most of them you're going to learn more in terms 4 and 5. Ghrelin makes you hungry. So ghrelin, don't forget, it increases the appetite. This is increase in Prader-Willi syndrome. What is Prader-Willi syndrome from term 1? Prader-Willi, signs and symptoms.
Defect on the chromosome 15, where you're either missing or in Prader-Willi, it's the SNRPN gene.
Is this a paternal deletion or maternal deletion?
Paternal.
Careful. So it begins with P, Prader-Willi, so it's a paternal deletion. Therefore, this is your maternal uniparental trisomy. Okay, don't forget that one. Chromosome 15, chromosome 15. Good job. Okay, we're on the home stretch. Intrinsic factor, of course, from the parietal cells. This is your vitamin B12 binding protein. This is required for B12 uptake in terminal ileum. So if I don't have intrinsic factor, if I cut off part of my stomach, can I still absorb vitamin B12? No, you cannot, because it needs the intrinsic factor. Okay? Even though there's a lot of vitamin B12 flowing in your body, if you don't have intrinsic factor, then it cannot be absorbed in the terminal ileum. Gastric acid, we all know that. Parietal cells, it decreases the stomach pH. These are the regulation that I'm talking about. Histamine, you have the vagal stimulation via acetylcholine and gastrin. Okay, that's high yield. Pepsin, chief cells. This is for protein digestion, right? Don't forget, there's an active protein called pepsinogen, which is converted to pepsin in the presence of H+. And of course, the bicarbonate from the Brunner glands in your duodenum to neutralize the acid. Why do we need to neutralize the acid in the duodenum? So that your pancreatic enzymes can actually work. right? Remember, they are secreted in active form, and they need to be activated. Again, this is your GI secretory cells. Your parietal cells, they secrete HCl, right? And then you have the chief cells, they secrete pepsinogen, the G cells, mucous cells, D cells, which secrete somatostatin, the I cells, S cells, and K cells. So let's do some thought experiment here. So you eat, right? So you eat here. What happens next? So we have increase in HCl. How am I going to increase my hydrochloric acid? In a couple of ways. The G cells will gonna secrete gastrin to the circulation, which increases the activation of your parietal cells to secrete what? HCl. Another way is for gastrin to activate the enterochromaffin-like cells, which increases histamine levels. The increase in histamine will gonna induce your parietal cells to increase production of your HCl, or you increase the vagal nerve stimulation. Look at this, this is your vagal nerve. Your post-vagal efferent will gonna connect with your G cells to increase the production of gastrin. After that, the acidity of the stomach is there. If there's a protein, right? But chief cells also can secrete pepsinogen. The mucous cells can secrete also mucus, right? D cells, don't forget, somatostatin. When it goes to the antrum, you need all of that acidity to be neutralized. So you have somatostatin. When it goes to the duodenum, now this is the first part of the duodenum, you have the I cells that secretes CCK, cholecystokinin. You have the S cells that secrete secretin, your bicarbs, and you have the K cells that secretes GIP. Again, know the enzyme. Amylase, think about starch digestion. Lipase, lipids, think about fat digestion. Protease, protein, right? Protein, think about protein digestion. These are your trypsins, chymotrypsins, your elastase, and carboxypeptidase. Trypsinogen is very high yield because it can be converted to trypsin, and this trypsin, it cleaves other trypsinogen molecules into active trypsin. Don't forget that trypsinogen is converted to trypsin via what? Enterokinase, or the enteropeptidase, which is a brush border enzyme on the duodenum and your jejunal mucosa. Trypsin is very important because it activates other pro-enzymes, okay? In terms of carbohydrate absorption, do I need to know the GLUT? GLUT1, GLUT2, GLUT3, GLUT4, GLUT5, SGLT1. I think, yes, you can memorize that one. What's the high yield? Glucose and galactose are taken by SGLT1. This is sodium dependent. With the co-transport of sodium, glucose or galactose enters your hepatocytes. Fructose is taken up via GLUT5. Don't forget that. 5 fructose, facilitated diffusion, and all the rest are transported to blood by GLUT2, so your DOS. Another high yield point here is this, the D-xylose absorption test. I think you can know more of this in term 4. So this is simple sugar that requires intact mucosa for absorption, but it does not require digestive enzymes. So it helps you distinguish between a GI damage from the other causes of malabsorption. So this measures the absorption of a simple sugar. And in order to absorb, remember, simple sugar, you need GLUT2 from the enterocytes, right? It does not require digestive enzymes. Again, vitamin mineral absorption, iron for bro, iron duodenum, folate, small bowel, B12 is your terminal ileum. Pyrex patches, we talk about this one, Pyrex patches. They are in your ileum and they contain high yield. When you think about M cells, think about your immune cells. Term 3, you're going to learn about B cells. They are stimulated in the germinal centers of your Pyrex patches to differentiate between plasma cells. And when you think about Pyrex Patches, also think about IgA. More of this in next term, term 3, which receives a protective secretory component. So any mucous membrane has IgA in there. So it protects your mucous membranes. So any kind of intraluminal antigen that invades your gut, think about IgA, okay? The intragut antibody. When we're talking about the bile, what's the precursor of the bile? Bile salts. Do we need to do something for the bile salts? Yes, you need to conjugate them. To what? High yield glycine or taurine. Why? To make them water soluble. Another high yield, what's the enzyme that catalyzes the rate limiting step of bile acid synthesis? Cholesterol 7 alpha hydroxylase. What's the function of your bile? Digestion and absorption of lipids and fat soluble vitamins, your ADEK, ADEK, cholesterol excretion, of course, and antimicrobial activity. Don't forget that there is a decreased absorption of enteric bile salts if you have Crohn's disease and short bowel syndrome. More of this in term 4, and it prevents normal fat absorption. You can also have increased frequency of calcium oxalate kidney stones if you have decrease in your bile production, because the calcium, which normally binds to your oxalate, it binds to the fat instead, so the oxalate is absorbed by your gut. Bilirubin metabolism, direct and indirect bilirubin. So from your macrophages, you have the RBCs, the heme becomes bilirubin, unconjugated bilirubin. This is indirect bilirubin, which is water insoluble. The unconjugated bilirubin, they cannot just go into the blood. They need to be conjugated by your albumin to form unconjugated bilirubin albumin complex, and then it goes to the liver, where it is acted upon by your UDP, glucuronosyl transferase high yield. Put a star there. That's an enzyme that's high yield, which converts it to conjugated bilirubin or direct bilirubin, which is water soluble. Then it goes to the gut, where it is converted to urobilinogen via your gut bacteria. Don't forget that the microbiome of your body has a very important part in converting conjugated bilirubin to urobilinogen, and then the urobilinogen can be excreted in the feces as stercobilin. This causes brown color of your stool, or it can be excreted in the kidney as urobilin, which gives your urine a yellow color. Or most of them will gonna go back to the liver for enterohepatic circulation. Let's summarize here. Bilirubin heme metabolized by heme oxygenase to biliverdin, which is reduced to bilirubin. Don't forget, unconjugated bilirubin is removed from blood by the liver, conjugated with glucuronate and excreted in your bile. Direct bilirubin, this is the conjugated form, therefore it is water soluble. It dissolves in water. The indirect bilirubin is unconjugated bilirubin. This is water insoluble. You need to know both terms: conjugated, unconjugated, direct, and indirect. Okay? Achalasia. Let's look at the image on the left side. What can you see? You can see a dilated, right? A dilated proximal esophagus. So this is due to what? Failure of the lower esophageal sphincter to relax due to degeneration of your Auerbach's plexus of the esophageal wall. Your myenteric plexus has gone kaput. So when you look at the manometry findings, you can see absent peristalsis with high LES, lower esophageal sphincter resting pressure. So we have progressive dysphagia, right, to both solids and liquids. This is not a simple obstruction. If it is obstruction, then you cannot eat solid foods only. So in the barium swallow, you can have a dilated esophagus here. Look at that. That's big. We call this one a bird's beak appearance. With an area of, look at the stenosis, right? The sphincter. You can have a dilated esophagus with an area of distal stenosis. So what if I have achalasia? You have increased risk of your esophageal cancer. So achalasia, A meaning without, relaxation. right? This is due to Chagas disease, Trypanosoma cruzi, more of that in term 3, or extraesophageal malignancies, mass effect or paraneoplastic, more of that in terms 4 and 5. So Chagas disease can cause achalasia. So let's summarize. Achalasia, what is it? Failure of lower esophageal sphincter to relax. Why? You have degeneration of your myenteric plexus. There is no Auerbach plexus, so there is no inhibitory neurons, which contains nitric oxide and VIP to relax that sphincter. What can we see in a manometry? We can see absent peristalsis with what? High LES, high lower esophageal sphincter resting pressure. So the patient cannot drink or eat. So progressive dysphagia to solids and liquids. What can we see in a barium swallow? Look at the left-hand side image here. You can see dilated esophagus proximally with an area of stenosis. You have the distal stenosis. We call this one a bird's beak appearance. So what if I have achalasia? You have an increased risk of esophageal cancer. Secondary achalasia can be seen in Chagas disease, Trypanosoma cruzi infection, or other extraesophageal malignancies. Barrett's esophagus, another high yield. This is specialized intestinal metaplasia. You have a replacement of your non-keratinized stratified squamous epithelium. This is the normal epithelium of your esophagus with intestinal epithelium, non-ciliated columnar with goblet cells in the distal esophagus. This is due to what? GERD. If you have gastroesophageal reflux disease, this is associated with increased risk of esophageal adenocarcinoma. So we can see here, this is the esophagus. This is your lower esophageal sphincter, right? Remember, failure of relaxation of this is achalasia. This is your junction, squamocolumnar junction, and this is your stomach. So you have, if the stomach, right, is very, very acidic, it keeps on eroding here. Keeps on going up due to increased intra-abdominal pressure. It keeps on eroding this squamocolumnar epithelial junction. That's why you have this one here. You can have intestinal metaplasia that is changing the normal tissue of your esophagus, which is non-keratinized stratified squamous epithelium. So you can see here intestinal metaplasia on the upper left part. You can have, look at this one here. See that? That's your intestinal metaplasia. Most of that is non-keratinized stratified squamous epithelium. So what if I have Barrett's esophagus? It increases your risk of esophageal adenocarcinoma. Peptic ulcer disease. What's the difference between gastric ulcer and duodenal ulcer? That's high yield. Gastric ulcer greater with meals. So you can't eat because, right? Because if you eat, the pain gets worse. So you have weight loss. This is due to what? Decreased mucosal protection against gastric acid. So if you keep on popping NSAIDs, right? If you keep on popping NSAIDs, you can develop gastric ulcer. Does this increase the risk of carcinoma? Yes, it increases the risk of carcinoma. Contrast this one with duodenal ulcer, which decreases with meals. So if you keep on eating, there is no pain. So you have weight gain. This is due to what? Decreased mucosal protection or increased gastric acid secretion. Other causes is Zollinger-Ellison syndrome. No risk of carcinoma whatsoever. This is benign. So let's summarize. Gastric ulcer, pain is greater with meals, so you have weight loss. Commonly due to NSAIDs, increased risk of carcinoma. Duodenal ulcer, the pain decreases with meals, so you can have weight gain. Cause is Zollinger-Ellison syndrome. No risk of carcinoma. It's generally benign. Appendicitis is acute inflammation of the appendix due to obstruction of your fecalith in adults, okay? If it's an adult, this is due to a fecalith, or in children, most commonly, this is due to lymphoid hyperplasia. This is proximal obstruction of your lumen. So why do you have pain in appendicitis? Why do you have pain in appendicitis? Anyone? What causes the pain? When can you have the pain? Remember, let me rephrase the question. When can you have the pain localized in the right lower quadrant? Because the onset of appendicitis, you can only have pain in epigastric region, right? And then it becomes localized in the right lower quadrant. Why?
When the inflammation touches the body wall.
Specifically what? You're almost there. You're right. You're almost there. When it touches what?
Would it be the parietal peritoneum?
Excellent. Excellent. You can, when it touches your parietal peritoneum, remember, if you have an obstruction, right, it increases the intraluminal pressure. So it stimulates your T8 and T10, your visceral afferent nerve fibers, which causes periumbilical pain at first. However, the inflammation then extends to your serosa, and then it irritates your parietal peritoneum. That's why the pain will going to be localized to the right lower quadrant, or the McBurney's point. Don't forget, what is the McBurney's point? This is 1/3 distance from where to where? From your right ACEs, anterior superior iliac spine, to your umbilicus, right? It can cause nausea and fever. It may perforate, so you can have peritonitis. Don't forget the signs: psoas, positive psoas sign, obturator, and Rovsing's sign. When I think when I was in term 2, we have OSCE, and I think I remember psoas, obturator, and Rovsing's. They will gonna teach you more of these in terms 4 and 5. Okay. You can also have guarding and rebound tenderness on physical exam. I think psoas and obturator sign is when you flex the leg, right? Of the obturator sign, or psoas when you the leg is straight and you raise it up, it elicits pain. Rovsing's, if you put pressure on the left quadrant, left lower quadrant, it elicits pain on the right lower quadrant. This is your Rovsing's sign, but more of these when you're in terms 4 and 5. So there are other parts that can have pain, right, in your right lower quadrant. So you need to have a differential. Either it can be diverticulitis, elderly. So first you have diverticulosis, right? So you have the increased pressure, intraluminal pressure of your large intestine. So you have the outpouching of your haustra there. And then this is due to low fiber in the diet. So it can cause constipation. So chronic constipation can cause diverticulosis, which can develop into inflammation, diverticulitis in the elderly, or ectopic pregnancy. Remember ectopic pregnancy, right? So you need to use HCG to rule out ectopic pregnancy. Most common site of ectopic pregnancy? Where?
The amphiuterine pouch.
Ampulla, right? Don't forget ampulla. So what's the treatment? You could do appendectomy. Again, high yield. These two is high yield. Meckel's diverticulum. So you have an umbilicus here, and this is your Meckel's diverticulum. It is a true diverticulum, meaning all of the 3 layers are involved. What's the embryological defect? High yield persistence of the vitelline duct, or the omphalomesenteric duct. Another high yield point, the tissue. When you biopsy the tissue here, it contains acid secreting gastric mucosa or pancreatic tissue. Okay, that's high yield. Most common congenital anomaly of the GI tract. It can cause what? Hematochezia or melena, right lower quadrant pain, intussusception, volvulus or obstruction near terminal ileum. What is intussusception? What is intussusception, guys?
Is it where it like collapses on itself?
So you have a lead point, and the proximal portion, it telescopes into the distal portion, right? We call that intussusception. Rotavirus, right? very common. It can develop into susception. We're gonna learn more in term 4. Volvulus. How about volvulus? What is this? Volvulus.
Twisting.
Excellent. So you can have abnormal rotation of the gut or obstruction in your terminal ileum. So when you contrast this one, you have your omphallomesenteric cyst. Omphallomesenteric cyst is just a cystic dilation. It's not a true diverticulum. Okay. How are we going to diagnose MECOS? High yield technetium pertechnetate scan, or the MECO scan. So you look for the uptake of heterotrophic gastric mucosa. You need to know the rule of twos. This is high yield. Most likely in males, 2 inches long, 2 feet from the valve, 2% of population, and it presents in the first 2 years of life. Hirschsprung disease, another high yield. This is congenital megacolon. What's the embryological defect here? Lack of ganglion cells or your enteric nervous plexus. So meaning you have no Auerbach's and Meissner plexus. So there are no nerves there. Okay, in the distal segment of the colon. Another embryological defect, if not that, is failure of neural crest cell migration. That's high yield. Failure of neural crest cell migration, most associated with RET mutations, a loss of function mutation. So what can we see? Bilus emesis, so they vomit with bile. Abdominal distension, failure to pass meconium within 48 hours. That's high yield. In the vignette, failure to pass meconium within 48 hours. That's why you have chronic constipation. So you can see here you have a normal part of the colon. You have nerve plexus there. Then suddenly you have an enlarged colon, right? So normal portion of the colon proximal to the aganglionic segment. So the dilated part, the enlarged part of the colon is aganglionic. No Auerbach's and Meissner's plexus is there. Okay. So increased risk of what? For Hirschsprung disease with Down syndrome. So if you have Down syndrome, you can have Hirschsprung disease, and don't forget duodenal atresia. Again, increased risk. If you do a squirt sign, don't do this in your clinical rotations. You can have explosive expulsion of feces. So if you do the squirt sign, the neonate can empty their rectum via digital rectal examination. So you have explosive expulsion of feces. This is diagnosed by rectal suction biopsy, high yield, and you can see absence of ganglionic cells. Remember, the neural crest cell, they forgot to migrate there. Okay, so what's the treatment? You just resect it. You cut the enlarged colon. Okay. Again, put a star here. This is high yield malrotation. Someone have said it, midgut rotation, anomaly during fetal development, improper positioning of the bowel. You can also see formation of fibrous bands. If in the vignette they say fibrous bands or lad bands, think about malrotation. It can lead to valvulus and it can lead to duodenal obstruction. Another high yield is intussusception. Remember, the proximal bowel segment, it telescopes into a distal segment, commonly in your ileocecal junction. It is idiopathic, but it can be due to a lead point. So you have a compromised blood supply. They're gonna say in the vignette, current jelly dark red stools. That's your keyword for intussusception. So in children, it is due to what? MECOS diverticulum. In adults, it is due to intraluminal mass. So on physical exam, you can ask the patient to draw their legs to the chest to ease the pain. And then you palpate, you can palpate a sausage-shaped mass. Okay, on imaging, here, you may show the target sign. It can be associated with IgA vasculitis, your Henoch-Schönlein purpura, more in term 4, or a recent viral infection. For example, your adenovirus and your Pyrex Patches hypertrophy, which can create a lead point. So there needs to be a lead point here first before the development of your intussusception. However, most commonly this is idiopathic. Okay, and the rotavirus, don't forget the rotavirus vaccine. You can one of the risk factor is you can develop intussusception. Again, volvulus, twisting of portion of bowel around its mesentery. So you have a mesentery, and then a portion of the bowel, it twists around that mesentery. It can lead to obstruction and infarction. It can occur throughout the GI tract. So midgut volvulus, more common in minors, children, and infants. Sigmoid volvulus, you can see here the coffee bean sign here. You have the coffee bean sign. Look at this one. Looks like a coffee bean. I don't know if you can see it. Look at this. This is a coffee bean sign. More common in seniors, elderly. So for volvulus, a portion of the bowel, it twists around a mesentery. Okay? It can lead to obstruction and infarction. Midgut volvulus, more common in children or minors, and sigmoid volvulus, more common in seniors or the elderly. Another high yield, cirrhosis and portal hypertension. Cirrhosis is you have diffuse fibrosis. What causes cirrhosis? Your ito cells, your hepatic stellate cells. They secrete TGF-beta. And you have regenerative nodules, disrupt the normal architecture of the liver. So what if I have cirrhosis? You have an increased risk for hepatocellular carcinoma. Look at this portion here, the image on the lower left. Hepatocellular carcinoma. What are the things that can give you cirrhosis? If you're a chronic alcoholic, okay? Or if you eat a lot of fat, non-alcoholic steatohepatitis. Or if you've been exposed to viral infection, specifically your chronic viral hepatitis. Don't forget, zone 1 is most commonly affected in your chronic viral hepatitis, and zone 3 is most commonly affected in your alcoholic hepatitis, or just autoimmune. If you have SLE, you can have autoimmune hepatitis, or you have a biliary disease, there's an obstruction in your bile duct, or genetic metabolic disorders. How about portal hypertension? This is increase in pressure in portal venous system. So what are the etiologies? What can give you portal hypertension? Cirrhosis, this is the most common cause, high yield in Western countries, cirrhosis. Or you can have vascular obstruction, a portal vein thrombosis. There is a thrombosis in your portal vein, or Budd-Chiari syndrome. There is a thrombosis in your hepatic portal vein, or due to schistosomiasis, which is, you're going to learn more in term 3, your Manzoni, your schistosoma Manzoni, schistosoma japonicum, schistosoma manzonic. It can give you transitional cancer of the bladder, or urothelial carcinoma. Do I need to know the signs and symptoms of portal hypertension? They're going to describe it to you in the vignette, so you need to pay attention. You can have jaundice, spider angioma, palmar erythema, purpura, petechia. You can have hematemesis, vomiting of blood. You can have melena, blood in the stools. You can have caput medusa. You can have ascites. You can have anorectal varices. Remember, you have an increased pressure in your portal venous system. Okay. You can have hepatic encephalopathy or asterixis, the flapping tremor, right? You have a disruption in your urea cycle. You increase ammonia in the blood. That's why you have asterixis, flapping tremor. GI, anorexia, nausea, vomiting. You can have thrombocytopenia, anemia, coagulation disorders. Your spleen will gonna work overtime. You can have splenomegaly. You can also have hyperbilirubinemia and hyponatremia. In terms of your heart, you can have cardiomyopathy and peripheral edema. Serum markers of liver pathology, put a star here. This is high yield. AST and ALT. ALT is increase in most liver disease. If the liver is attacked, for example, in your hepatitis, the liver architecture is attacked, ALT is increased more than your AST. So the L in ALT, think about liver, right? Specifically the liver. AST is only increased in alcoholics. Okay, if in the vignette they say chronic alcoholic, look at the ALT, AST. The AST should be increased, right? Another one is alkaline phosphatase. Alkaline phosphatase, this is increase in cholestasis. There's an obstruction in your bile duct or any kinds of bone disease. So this is not specific, okay? Any increase in alkaline phosphatase can mean there's an obstruction in your biliary duct or any kind of bone disease, right? Paget's disease, for example, more in term 4. Another one is your GGT. GGT, right? This is always associated with alcohol use, okay? So when in the vignette there's alcohol use, I want you to look at the AST level. Compare that with the ALT. The AST should be increased, right? If that's iffy, check the GGT. If GGT or your gamma glutamyl transpeptidase is increased, then it is alcohol use. Okay? If it's hepatitis, right? In the vignette, they're describing an hepatitis, and you want to make sure, and they give you a serum marker. Check ALT, your alanine amino transferase. It should be much larger than your AST. Okay. Another functional liver markers, high yield, your bilirubin. This is increased, of course, if you have obstruction or alcoholic or viral hepatitis, and cirrhosis and hemolysis. Any kind of G6PD deficiency, sickle cell anemia, it can increase your bilirubin. Albumin, don't forget, it is decrease in advanced liver disease. High yield, this is a marker of the biosynthetic function of your liver. Okay, that's your albumin. PT, right? Increase in advanced liver disease. PT-INR, what pathway? Extrinsic or intrinsic pathway of the coagulation cascade? PT-INR, extrinsic.
Intrinsic.
Careful.
Extrinsic.
Extrinsic pathway. Remember extrinsic pathway, the factor 7, right? Your warfarin, right? PT-INR. Don't forget that the intrinsic pathway is your APTT, your partial prothrombin time. Okay, so PT is increase in advanced liver disease. So you have a decreased production of your clotting factors, thereby measuring the liver's biosynthetic function. Platelets is also decrease in advanced liver disease. So the liver is very important, people, right? So you have a decrease in thrombopoietin, and you can have portal hypertension. Platelets is also decreased in splenomegaly, splenic sequestration if someone has sickle cell disease, for example. So put a star here. This is very important. Another thing, how am I going to know if it's viral hepatitis versus alcoholic hepatitis? Look at the AST-ALT again. Serum marker. If it's viral hepatitis, ALT is increased more than the AST. And if it's alcoholic hepatitis, AST is increased more than your ALT. And look at the GGT. GGT should always be increased, okay? Careful with that when you're reading your vignette. So jaundice, what is jaundice? This is abnormal yellowing of the skin due to what? Bilirubin deposition. So if you have hyperbilirubinemia, secondary to increased production, or for example, there's something wrong with your liver, you have impaired hepatic uptake, there is no conjugation, there's wrong with excretion of bilirubin, you can have jaundice. It can either be due to hemolysis or obstruction or tumor or liver disease. So conjugated direct hyperbilirubinemia, when you think about this, think about obstruction. Obstruction, think about conjugated direct hyperbilirubinemia. So due to gallstones, cholangiocarcinoma, pancreatic or liver cancer, or your liver fluke, your schistosoma, it can either be due to primary sclerosing cholangitis or primary biliary cholangitis, or Dubin-Johnson syndrome and your Rotor syndrome. There's something wrong with your UDP glucuronidase transferase here. Okay, conjugated direct hyperbilirubinemia. What if I have unconjugated or indirect hyperbilirubinemia. What diseases can cause an increase of these? Hemolysis, think about hemolysis, okay? Think about G6PD deficiency. Think about sickle cell anemia. It can be physiologic in newborns, yes. That's why they need to be treated with phototherapy. You need to expose them with UV light to make the unconjugated indirect bilirubin soluble, water soluble. Crigler-Najjar and Gilbert syndrome can also give you unconjugated or indirect hyperbilirubinemia. What if it's mixed? You have both increase in conjugated or direct bilirubin and unconjugated indirect bilirubin. Then it can either be hepatitis or cirrhosis. Okay? So put a star here. This is high yield. Know the difference between conjugated or direct bilirubin and unconjugated indirect bilirubin. Know the diseases that's involved if they are increased, right? And of course, mixed. If both of them are increased, it is probably due to either hepatitis, viral hepatitis, or alcoholic hepatitis, or cirrhosis. That's why you need the serum markers from the previous slide to make a good diagnosis. Again, high yield, put a star here. Your hereditary hyperbilirubinemia, meaning you have an increase in bilirubin, but it depends, right? So these are all autosomal recessive. For Gilbert syndrome, you have a mildly decrease in UDP, glucuronosyl transferase, right? So mildly decrease. So this is asymptomatic. You can have mild jaundice in the patient. So you have an increase in unconjugated bilirubin without hemolysis. This is common, this is benign. The worst is Crigler-Najjar syndrome. This is absent UDP, glucuronosyl transferase, right? So you can have jaundice, kernicterus, you have increase in unconjugated bilirubin. Remember, bilirubin cannot be broken down, okay? So what's the treatment? You can do phototherapy. You can do liver transplant is the cure for this, right? Dubin-Johnson, you have an increased conjugated bilirubin due to what? Defective liver excretion. In the vignette, they're gonna say dark liver. When you see dark liver, think Dubin-Johnson syndrome. Rotor syndrome is similar to Dubin-Johnson, however, it's milder in presentation without the black liver. If there's no black liver, think about Rotor syndrome. So Gilbert syndrome and Crigler-Najjar syndrome, you have an increase in your, what is increased here? Gilbert syndrome and Crigler.
Unconjugated bilirubin.
Excellent. So increase in your unconjugated bilirubin. You're indirect. How about the Dubin-Johnson syndrome and Rotor syndrome? Your conjugated bilirubin, your direct bilirubin is increased. Last slide for the anatomy and physiology portion. So Wilson's disease, hemochromatosis. Put a star here. This is high yield. So Wilson's disease, this is there's something wrong with your copper transporting ATPase, your ATP7B, okay, on chromosome 13, meaning you have decreased copper. So in the vignette, they're gonna say decreased serum ceruloplasmin. When you see that, think about Wilson's disease. So what if I don't absorb copper, right? So it accumulates in your liver, in your brain, your cornea, your kidneys. When you check the urine, you have an increased excretion of the copper in your urine. What can we see? What are the signs and symptoms? They're gonna describe it to you. So you can have
Kaiser rings.
Exactly, Kaiser rings. What part of the cornea is it deposited? Decimate membrane, high yield. You're gonna learn in the next module about the decimate membrane of the cornea. So that's where the copper is deposited. It can also be due to Fanconi syndrome. More of this in term 4, a renal disorder. So what's the treatment? High yield penicillamine. Penicillamine. You can also zinc. If this doesn't work, then last resort, liver transplant. Wilson's disease, ATP7B gene, chromosome 13, decreased serum ceruloplasmin, psychiatric disorders. You can have tremor, Parkinsonism, and Kaiser-Fleischer rings. You can also have Fanconi syndrome. What's the treatment? Penicillamine, liver transplant, last resort. Hemochromatosis, on the other hand, there's something wrong with the HFE gene, chromosome 6. This is associated with HLA-A3. So you can have abnormal iron sensing. So you have increase in iron. So for now, I think memorize this one. What happens to ferritin? What happens to TIBC? What happens to transferrin, right? So you have increase in iron. So you have increase in ferritin. Storage. This is the storage form of iron, ferritin, right? You have an increase in iron in the blood. And you have a increase in transferrin, the transfer of iron from the blood to your hepatocytes. And you have an increase in iron binding capacity, TIBC. So what if I have an abnormal iron sensing and I keep on absorbing iron, then iron will gonna accumulate, right? Think about those people who has chronic transfusions. Think about beta thalassemia major, right? Think about if the iron will gonna accumulate everywhere in the body. You can have the liver, you can have the pancreas. So when you get a biopsy and you stain it with Prussian blue, you're gonna see hemosiderin. These are your iron deposits. Look here on the lower left-hand side, the blue ones inside are your hemosiderin deposits. So it presents what? Classic triad: high-yield cirrhosis, diabetes mellitus, and skin pigmentation. This is your bronze diabetes. It can cause restrictive cardiomyopathy or dilated cardiomyopathy. Most common cause of death in hemochromatosis actually is cardiomyopathy. You can also have hypogonadism. So what's the treatment? Chelation. You can give drugs. Deferoxamine, deferiprone to remove the iron, or you can do repeated phlebotomy. Okay.
That's the one we discussed.
Women they are not prone to hemochromatosis. Why? Because every month you can have menstruation. Okay, they are not how do you call this one? They do not have increased risk of hemochromatosis up until menopause, though. Okay, I think that's it for now. Let's have a 10-minute break. All right, see you later.
Thank you.
You're welcome.